Hello everybody and welcome back to my channel. Today is going to be another sonography video. As you can see by the title, it's my fall break. Let me live a little. So today, which this is gonna be a little bit weird because this doesn't really apply to the majority of places, but so far with my experience, my clinical, we have to do this. And what I'm talking about are worksheets. So I'm gonna go over what I do and what a worksheet looks like. And number one, there's pros and cons to it because I think it's good experience to know your numbers, but also I feel like if you do it for so many times, you're like, okay, we get it. So I'm gonna go over what mine look like. If other sites do worksheets, they'll probably look different. So I can't promise you that every site looks the same. But I think, well, I like the way that my site does it because not only do they have the numbers on there, but they also have the normal values for some of them, for the most important pathologies that you're going to be seeing. So let's just get right into it. So I have two versions. I have kind of a blank version and then I have a highlighted version. Obviously I've marked out the name because, you know, HIPAA. It's not even HIPAA, it's a blank worksheet. This is not any patient's worksheet at all. The only thing I've written is patient name. The patient name would go up here. Their MRN number, which usually starts with a 9, that would go up here. Then the date, obviously. So on this sheet, I have highlighted everything that I have to fill out for each patient that I scan. Obviously, this is an example. This is not anybody's actual information. I just want to say that, make that very clear, okay? So let's just go over it real quick. I'm gonna move a little bit so you guys can see it. So usually what I start off with is I get the patient chart, which is usually on a computer. Sometimes it's on paper, but I've never experienced that. That's older, but I do know that some of the information, some of the old tests are in a folder chart. I've seen that in the hospital. So maybe you'll have to fill out a chart from their chart. But normally they're gonna be on a computer. They're gonna have their chart. They're gonna have all their history, all the past tests that they've done, and also all the results. So I would pull up their chart, and for that specific visit, the one that I will be doing, they have a specific MRN number. And I usually start off with their name, date of birth, MRN number. So the patient name goes up here. And a lot of the times I've actually found our patients like to be called by something else. Either a shortened version or just something totally different, which sometimes the totally different one is easier to say than the normal one. But I found a lot of people like to be called by nicknames. So patient name, the date of the scan, whether they're an inpatient, outpatient, outreach, or a clinic. I usually do inpatient or clinic because that's the two places that I work at. Their MRN number goes up there. And then we don't fill out the requisition number or the account number. We just don't have those, so we don't fill those out. Then on the next line is their date of birth, their age. It usually gives you the age, but for some patients I've had to calculate the age, which is fine, but normally they give you the age too. And then what sex they are, and then the ordering provider. I think, well, this isn't really accurate. Ordering provider, you don't have to write who ordered it, you have to write who you're giving it to. So we usually fill out who we give it to in this line. We don't fill out who wrote it because that information isn't practical in this situation. But if you're giving your study to a doctor to read, you need to write who you're giving it to. So we usually put that in the ordering provider line. So then the next line, height, weight. One thing that I've learned is definitely no like centimeters and no inches, because in the hospital, a lot of your height is going to be in inches. So learning to convert is very important, and just knowing your numbers. We don't usually do BSA. That is usually calculated on the machine, but we don't do anything with it. As far as I know, and as far as I have experienced, prior study, this would usually, it's more common to write prior study, yes, no, and the date for clinic, because normally clinics do have a lot of prior exams. But sometimes in the hospital, actually a lot of times in the hospital, they don't have studies done. And so majority of the time it's going to be, you just leave it blank because they don't have any, because their chart is just blank, which is good and a bad thing, because it's like less work for you, but also you have nothing to go off of, so you don't know anything, so you have to do a full write-up on this person, which is good, just a little bit time consuming. Then obviously technician, you would write your initials there. Heart rate and BP, in the hospital setting you can get it from the machine, or in their chart it's their last known heart rate and BP, which you could write it there, and then when you go up to the floor in the room, you can write it to the side. Clinic, they usually get the heart rate and the BP for you when they do their initial exam. So what I usually do is I wait until it updates and then write it on there, but sometimes, you know, time is just annoying, and so I just have to start the exam anyway and then write that later on. So lastly, up here is the indications for the study. Very important, because you want to know like why you're doing the study. And a lot of the time, 99% of the time, I've seen dyspnea, which is shortness of breath, and chest pain, or a previously known problem. Those are like the three most common that I've seen so far. And there's whole debate on doctors ordering things, but I'm not going to get into that, because obviously I'm not really experienced, but I've heard about it and everything. So you would write your indication here. I've personally had a little bit of trouble finding the way everything is set up. I still don't really know how to find a distinct, we are doing this exam because of XYZ, because the doctor's note is what you're looking for the last exam, and usually at the bottom are the conclusions, and in the conclusions you would find the reason for what you're doing this exam on. Really confusing, but you put your indication there. So then we move on to your numbers section. So you would fill all of this out before you do your study, and then once you're finished with your study and you have all your measurements and everything, you would fill this out. Now, some people, I know some sonographers fill it out during their exam, and a lot of the time they fill it out after the exam. So if you have to fill it out, I mean, either way, if you're more experienced and very efficient, either way I don't think would really matter. I do it after the exam because number one, I'm left-handed, so I have to scan with my left hand. I can't write. I mean, I can write with my right hand, but it's not pretty. So I typically wait until I'm done with the exam, and then when I'm finished, I do end exam, and then I do review, click on the last patient that I scanned, and then I do report, which I think is normal for all of the machines. And then it comes up with all of your numbers. So some people like to write numbers from the image itself in the order that they scanned it, which is fine, but I typically can't see that small. I mean, I can, but it takes me longer to write it down than to just see a whole page of numbers. So obviously when you're scanning, the first, well, actually everybody's protocol is different. My protocol, I start off with measuring the LVOT, and then the LA, MV annulus, and then the aortic root, and then the ascending aorta. So those are the first set of measurements that I do, and every machine puts the report in different like order. So it's not gonna be in the order that you scanned it necessarily. There's like one machine that does it in the order that you scan it. I'm like, perfect, boom, 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 boom. But life doesn't work that way apparently. So I usually start off with my systole diastole measurements, which are over here. They're not in order, which is stupid. But you have your RVD here, RVID, RVD. You would do that one first, and then you would just fill it out because I think RVD, IVS diastole, LVID diastole, LV posterior wall diastole, and then my measurement does LVID systole, just the septum to the posterior wall in systole. I can't remember what other, because when we learned to measure from one teacher, you would do your diastole measurement, and then you would do your IVS, your chamber, and then your posterior wall. But now I'm learning that you just do your chamber for systole. I don't know if it's like that for every site, but at least my site just does the chamber size in systole. And normally when you do your chamber size in systole, you also get your EF, which very, very, very big topic is your EF. EF and diastolic dysfunction, which I didn't learn a lot about diastolic dysfunction until, I'm still learning about it because we didn't learn about it, which is amazing. But depending on their previous study and their previous exams, if they've had any, then you could kind of get a general idea of their EF, and it's usually in the report. So like 55-60 is the normal percentage that you would have as a healthy human heart. Obviously anything below is diastolic dysfunction, depending on the grade, which I'll talk about that later. So usually with your systole diastole measurements, you can kind of get a general idea of what your EF is going to be. It's going to be this spot right here. EF, 2D EF measurement there. So you can kind of get a feel for how their heart looks when you're doing your measurements, which there's so many like little things. So when you start off scanning, you're like, just get the picture, get the measurements, move on. I'm learning, get the picture, get the measurements, look at the function, predict it, and then assess. And it's been difficult because I wish we had started doing that in school, but you don't do that in school. So it's really difficult to like switch that mind of not just getting your image, but also looking at your image. So that's what I'm learning now. So then after that, this whole section is good. Then usually your LVOT diameter, I forgot to highlight that one. Your LVOT diameter goes down there. And then I think sometimes my IVC, IVS, IVC, I don't know. IVC goes in there as well. And then when you're watching your IVC, obviously you would circle normal for the respiratory variation. Obviously, if they have problems and it doesn't collapse, then you would do abnormal. That necessarily, the majority of the time, they're going to collapse. What I'm trying to say is, you don't really have to write it on here if they collapse or not, because you're just going to write it in their chart, and the doctor already knows, more or less. So then, also with your first section, you would write your LA volume index, which I think like 30s, 40s is pretty good. Yeah, 16 to 28 is normal. 29 to 33 is mild. So normally I have like 20s and 30s people. So it's kind of in the mild range. Obviously your rhythm, NSR, normal sinus rhythm, unless they're like an AFib. AFib or a flutter. I've had people with AFib and it's annoying. I think AFib or a flutter. I don't know. But one of those two, you have to measure a whole bunch of things and then it gives you an average because you can't really tell the correct waveform, ejection, like it's really frustrating. So you pray that they're in normal sinus when you're scanning them. Then you would do that. So then next comes your valves. So you have like your kind of overall stuff. Oh, and then you would put your aortic root, ascending aorta, LA atrium, MV annulus there. So these are like your first, the next section. Then we go on to your valves. I would say the mitral and aortic valve are the most important. Obviously, they're the most common to have things with problems, and then the tricuspid is this like third. Pulmonic, it's like that poor person that you don't think about a lot because barely anything happens with the pulmonic, at least from my experience right now. Not a lot goes on, okay? And I've learned, I thought you could see the pulmonic valve a lot in views, but apparently, obviously everybody's different, so you don't see it a lot. So if you can't see it, you can't say anything about it. Which I've learned is like, oh, that makes sense. Because I was used to scanning healthy people, and healthy people you can see the valve. I'm not scanning healthy people now, so I can't see the valve, so I can't say anything about it. So, start off with your aorta. We usually do the Vmax and the LVOT velocity as well as the LVOT diameter, which I forgot to highlight. If they have problems like aortic stenosis, then you would get your peak gradient with PEDOF, as well as you would try to do it in your waveform in Doppler. Then you would do your pressure halftime too, as well as like your VTI. So you would do gradient. Then you would also, in my protocol, you zoom up on the valve and you prove that it's tri-leaflet, which when we switched teachers, before we were just getting the view, we weren't getting to that spot to show that it's tri-leaflet, which was a whole like, oh boy, for me. Because now it's like, now I understand like, oh, that's not the accurate view because you can't see the leaflets in the aortic valve. And then you move and then you tilt and then you like meander your way into the view of where you can see it. And I'm like, that makes sense. So for me, it's like, now I know why I struggled so much and what they were talking about. Now I can see the leaflets. So when you're on the aortic valve, you want to show that it's tri-leaflet if it is tri-leaflet, because then you either prove it is or it isn't. I've had a couple of patients who are bileaflet? Bicuspid, sorry, not bileaflet, oh my goodness. Bicuspid aortic valve. Usually genetic or a disease, so. Aortic valve is done. The next big one is the mitral valve. Usually you do your E and your A. We only report the E for the max. E and then decel time, and then your E to A ratio, which is the other big one, which also proves diastolic dysfunction. So if it's anything less than 0.8, it's grade 1, which grade 1 diastolic can be fixed, okay? If it's anything over 0.8 to 1.5, it's grade 2. Grade 2 cannot be fixed. You can't do anything about it. You're screwed, basically. Then obviously your really sick patients is greater than 2 EDA. So, big one too. So yeah. And then if there's any like mitral stenosis or regurg, for regurg, we do PISA, which I'm not going to talk about. It's like, ugh. You would just do your VTI and then you would measure the little mushroom, and then you would do the bottom aliasing velocity. Sorry, lower your color box. I always forget that one. So, PISA section is over here. They do the ERO, the MR velocity. Then you would say trace, mild, moderate, severe. Normally it's trace or mild, but then there are the patients who have severe. I did a severe patient, and it's it's severe. I mean, on color Doppler it looks worse than it actually is, but you have to look at it and then do the waveform, and the waveform will really like show you how severe it is, because looks can be deceiving for the color. Like I've seen a lot of like, oh boy, that's gonna be a bad one, but then on the waveform it's not that bad. Like AI, that's one of the things that I always like get tripped up on about with aortic insufficiency. Also, insufficiency and regurgitation are the same thing. I learned that. So a lot of people will say AI, not AR. And then they use regurgitation for the rest of it, like MR, TR. They say PI and AI, MR and TR. So everybody's different. But PISA, then your TDI is over here, which I personally like. I don't know why. It's just that fun little thing that you get to do. In school, we did the E, the A, and then like last, we did the S, which you would only do S if they had right-sided problems. Which I'd like it clicked for me that you do that. But you do your medial E, lateral E, E prime, and then velocity. Fill out those numbers. Then your pulmonic velocity, if they have PI, then you would fill it out there. Just do a peak, so it would be like a Vmax, PV max. Then tricuspid, if you have tricuspid regurgitation, then you would do your TV max, TR max, sorry. And then you would just put your jet thing here. With TR also, if it's a certain amount of TR, you have to talk about hypertension, as well as filling out the RVSP thing right here. If it's severe enough. That also goes with your IVC. With your IVC, with enough tricuspid regurgitation, it can get into the IVC. So you have to be careful of that. Also, lastly, if you used contrast, I mean, it's not really contrast. I don't know how to describe it. We use we use Lumason. A decent amount. I wouldn't say a lot, but a decent amount on people, because the bigger you are, the harder you're going to be able to see it, because there's just a lot more space to go through to get to the heart and come back. So obviously, if you take physics, it's gonna lose your basically. So you would put whether you use Lumason or Definity down here. So that's everything for the numbers. Then there's this chart down here, which it looks like a mess, but let me go get my other one. I did a third one of where I colored it and everything. Learning the numbers, you're gonna need to know the normal values, okay? That's something that I'm working on right now. You would need to start, like, if you're in the program, learn your numbers. Like with my program, I think it kind of screwed us because we had to do 2 things, like 2 courses, whole like 4-year things in 2 years for 2 different things. And we were so busy just learning enough and moving on to the next thing that we didn't like sit down and like know it. And half, I think it's half on the student, half on the program, because like, I don't know. We didn't get like sit down and understand why the numbers are important and what are the normal numbers. So this chart I've color coded. I've also written up like just a paper version of it. I'm not gonna go through this whole thing. I might make a different video for it, but I've colored it for green is normal, yellow is mild, orange is moderate, and pink, which is technically like red, is severe. So you might, if you want, you can take a picture of it. But I will be doing a different video explaining these and like why they're important, because technically this chart is just kind of a mess. So it took me a hot second to like figure out, because like this whole section goes over here and then this whole section is up here. So like it's not like one defined thing. So that's it for this video. That was a lot. But I thought that was kind of important to talk about because not a lot of sites do worksheets. But I think, at least for a little bit, it's good to do the whole thing just to know your numbers, to fill them out, and to just be like, know what you're looking for. At least for me. I don't know anybody else, but that's it for this video. Thank you for watching, and I will see you in the next one. Bye, guys.